Hello, I'm Patricia Kaufman, the co-founder and communications director of the CLL Society. I would like to welcome you to today's event, Revisiting PI3 kinase inhibitors for the treatment of CLL. Are they living up to their promise? We will learn about PI3 kinase inhibitors such as duvelisib, idelalisib, and the still experimental umbralisib, which offer potent and potentially helpful treatment options to CLL patients who have relapsed on or become refractory to other treatments. Dr. Ian Flinn will walk us through how PI3 kinase inhibitors work and discuss the common side effects. We would like to thank Adaptive Biotechnologies and Bristol Myers Squibb for making this webinar possible through their grant support. At this time, I would like to introduce Dr. Brian Kaufman, Executive Vice President and Chief Medical Officer of CLL Society.
Thank you, Patty. It's my pleasure to introduce today's speaker, who's really very experienced and done a lot of research on the topic, the PI3 kinase inhibitors. Dr. Ian Flinn is the director of the lymphoma research at the Sarah Cannon Research Institute. He also serves as the director of the Sarah Cannon Center for Blood Cancer at Tennessee Oncology and TriStar Centennial Medical Center. Dr. Flynn's research over the years has focused on the development of new therapies for patients with lymphoma and CLL. His research has included first-in-human trials to phase 3 trials that have led to drug approvals with novel approaches such as PI3 kinase inhibitors and also immune effector cell therapies, inhibitors of the B cell receptors, and BCL2 inhibitors. His research has been widely published in the most prestigious and high-impact medical journals, such as the New England Journal of Medicine, Lancet, Journal of Clinical Oncology, and Blood. Thank you again for joining us today. I now want to welcome Dr. Ian Flinn.
Thank you for joining today's program. I'm Ian Flinn from the Sarah Cannon Research Institute and Tennessee Oncology in Nashville, Tennessee. Today I'm going to discuss PI3 kinase inhibitors for the treatment of CLL. We're going to discuss the mechanism of action. We're going to discuss some of the data surrounding the approval of some of these therapies, as well as not only the efficacy, but also the side effects of these drugs. And finally, we're going to discuss a little bit about some of the future directions of making these therapies better. I think an understanding of how PI3 kinase inhibitors work, as well as perhaps any kinase inhibitor, starts with an understanding of signaling pathways. I use this example of a set of stairs. You could also think about steps in a ladder or links in a chain. Each step leads to the next level. And the analogy here is that by going through these different steps or the different links in the chain, one gets a message through that causes the cancer to grow and proliferate. A potential therapy for different cancers, including CLL, is to inhibit one of these different steps, put a block on these different steps, cut the link in the chain that leads to the growth of the cancer, in this case, again, CLL. Each of these different steps represents a different potential target. One of the targets that we're going to talk about today are the PI3K. There are now been different inhibitors of the PI3K, and so we can specifically target one of the steps along the way here and hopefully not get some of the side effects we see with other indiscriminate agents such as chemotherapy that not only inhibit these CLL cells, but also cause indiscriminate side effects to normal tissues in the body. Unfortunately, in cancer, it's never quite that specific. It's never quite that easy. in most cancers, there are many different signaling pathways that lead to the growth and survival of the cancer. And that's true in chronic lymphocytic leukemia. So you can think about it as a house with multiple different staircases, multiple different chains, multiple different ladders, all leading up to the next level or the growth of the cancer. And so what we'd really like to do is develop an inhibitor, a block in that staircase that blocks more than one of these staircases. And so with the PI3K, with the PI3 kinase inhibitors, and we have a very good target for that. This is a graphic representation. The details of this are not important for today's discussion, but I think what you can see that there are multiple different pathways, all leading through the PI3K. And by inhibiting this nexus, this connection of all these different pathways, the hope is that we can stop the malignancy from growing, in this case, chronic lymphocytic leukemia. There are many different reasons why these pathways are turned on, these signaling pathways. It can be from a genetic alteration that leads to the overstimulation of one of these pathways. It can be from interactions with the environment that turn on and make this pathway grow and make the cancer proliferate. Or it can also be almost like a autoimmune loop. It can be where the cancer itself can provide the signal to itself to make the cancer grow. But regardless, in chronic lymphocytic leukemia, the PI3K are an attractive target because they provide a common pathway, a common step in that ladder or in that staircase that by inhibiting it, that we can often cause the leukemia cells to die off and not grow, to break the chain, to take out one of the loops in the chain, to break that chain and prevent that signal from going forward and cause the cancer to regress and to go into remission. There are now several FDA-approved PI3 kinase inhibitors. The first one was idelalisib. It was approved now a number of years ago. It was approved for the treatment of chronic lymphocytic leukemia in combination with rituximab. More recently, we've seen the PI3 kinase inhibitor duvelisib approved as a single agent. It's an oral medication. It's a pill that's also approved for chronic lymphocytic leukemia. There are a couple other PI3 kinase inhibitors that are approved for other cancers, related diseases like follicular lymphoma or marginal zone lymphoma. They include copanlisib, which is approved for follicular lymphoma. It's different from the other PI3 kinase inhibitors in that it's an intravenous medication. It's an IV medication. And the drug umbralisib has also been recently approved for follicular lymphoma and marginal zone lymphoma. I'm going to show you some results in a few minutes about umbralisib's data in chronic lymphocytic leukemia. It's not yet approved, as I said, for CLL, but we anticipate that will get approved in the not too distant future. These inhibitors differ a little bit in their specificity for the PI3 kinase inhibitors that the PI3 kinase that they inhibit. But I'd have to say from the outset, they're more similar than they are dissimilar. Different doctors like different PI3 kinase inhibitors for different reasons. Some of it has to do with their adverse event profile or perceived adverse event profile. Sometimes it has to be whether they're given as a single agent or in combination with other agents. But I have to say, in general, they're more similar than they are dissimilar. So the first FDA-approved PI3 kinase inhibitor was idelalisib. This is a Kaplan-Meier curve from that study that led to the approval of idelalisib in combination with rituximab for patients with relapsed chronic lymphocytic leukemia. I think it is important to take a minute to explain these results. These are efficacy results showing an improvement in progression-free survival. This is what's called a Kaplan-Meier curve. On the horizontal axis, you see time, and on the vertical axis, you see what's a percentage. Basically, what in this case, it's percentage of patients that are progression-free, meaning percentage of patients that have their cancer, in this case, the CLL, has not gotten worse. It's either gone into remission or stayed stable, but it's not gotten worse. So perhaps the holy grail of cancer therapies would be a horizontal line starting at time 0 at the 100% level and going straight across and never coming down. What that would mean was that over time, no one's cancer got worse. In this case, CLL. No one's CLL progressed and never got worse. Perhaps many went into remission, but it never got worse. The worst outcome would be a vertical line starting at time 0 and going straight down, where within a couple days, everyone had progressed, and there are many different outcomes in between. Clearly, the line that is highest, closest to that top level, starting at 100% and moving across and staying at 100% would be best. And here you can see the blue line, which is idelalisib plus rituximab, is better than rituximab plus placebo by a long shot. I mean, it's a huge difference, as you can see here. And so this study was one of the studies that led to the approval of idelalisib for patients with relapsed CLL, because the addition of idelalisib to the monoclonal antibody rituximab was substantially better than just giving the monoclonal antibody rituximab by itself. This is an important concept to understand Kaplan-Meier curves in general, because I'm going to show you some in the future, and you'll probably come across this same analysis in other presentations. But idelalisib is not without side effects. We saw, even from the early phase 1 study that we conducted many years ago, that there was some increase in what we call the ALT and AST of the liver. These are liver enzymes. Basically, when they go up, it means that the liver is inflamed. You can see that with other forms of hepatitis, such as infectious hepatitis, like hepatitis B. You'll see liver function tests, the AST and ALT go up. In this case, it went up, but the good thing is as soon as you stop the drug, it gets better. And so for most people, it's not really a big deal. It's important for their doctor to follow patients on these medications. But in reality, patients almost never knew that they had any inflammation in the liver. Once you stop the drug, it gets better. You can often restart patients on this and it does not reoccur. Some patients had low neutrophil counts, and it varied in the degree of what we call neutropenia, low neutrophil count. Others will become anemic, and some patients had low platelets. You know that platelets are the cells that help us clot blood, and so having low platelets is significant. By and large, again, all these issues got better if you held the medication and waited, and the counts improved. And sometimes there were very transient decreases. There was another drug that was recently approved. It's known as duvelisib. Duvelisib is another oral PI3 kinase inhibitor. This is a little bit unique compared to idelalisib, in that not only did it inhibit the cancer cells, the B cells, the malignant B cells, but it also inhibited some of those those signals that come from, that I just mentioned previously, that came from some supporting cells in what we call the microenvironment. It inhibited those signals as well. And so the theory before, when we were just starting to investigate this drug duvelisib, is that perhaps there would be greater efficacy by inhibiting not only the malignant cell, but also sort of giving it a double whammy by inhibiting the cells that some of these survival signals, these cells that cause the some of those signaling events that I just said by inhibiting them as well. And so that was the theory behind the development of duvelisib. Well, you can see here, these are, again, another Kaplan-Meier curve of this large randomized controlled trial that was known as the DUO trial. In DUO, half the patients received duvelisib as a single agent, this time not with a CD20 antibody like rituximab, and the other half of the patients received ofatumumab. Ofatumumab is another anti-CD20 monoclonal antibody. And at the time this trial was conducted, was considered a standard option for patients with CLL. Well, again, what you're seeing here in this study is that duvelisib had a superior progression-free survival than what we saw with ofatumumab. Basically, the blue line that we're seeing here is superior to the red line, meaning it's higher up. And you can look at each of the different time points along the line here and see that the percentage of patients that corresponded with that time. So, for instance, the median, the number of patients that were in remission on duvelisib, the median progression-free survival was about 13.3 months, and that compares to the median progression-free survival with ofatumumab just shy of 10 months. I think one of the other important factors to understand, frankly, with all the PI3 kinase inhibitors and many other of the novel therapies that have now been approved for patients with CLL, is that they all seem to work across the different subtypes. Unlike what we saw with chemoimmunotherapy, where certain patient populations really didn't do very well with chemoimmunotherapy, like those patients who had deletion of the 17p or p53 mutation. With duvelisib and with idelalisib and with all the other PI3 kinase inhibitors, it really appears that across these different subgroups, patients did well. So it didn't matter whether it was a 17p deletion or a p53 mutation. It didn't matter whether someone was refractory to their last therapy or had early relapse, or were not refractory, or whether they came into the study with some of these already problems with their bone marrow function, such as having low platelet count, low neutrophil count, or anemia. All those different groups, no matter how you looked at it, patients did equally well with duvelisib. There wasn't a group that didn't do well with duvelisib compared to ofatumumab. The other important consideration, again, is some of these adverse events. So I went through some of the adverse events with laboratory abnormalities that we see with idelalisib, but with gives a little more detail with duvelisib. There are a common set of adverse events that we see with these class of drugs. They include infections, diarrhea or colitis, sometimes cutaneous reactions such as rash, and finally something called pneumonitis, and I'm going to explain that in a second. Well, infections are common, unfortunately, to almost all our therapies for chronic lymphocytic leukemia. I explain to my patients in general, you have to think of it as that you have a cancer of your immune system, and the immune system doesn't start out very well. And when we use therapies that inhibit the CLL cells, well, they're not necessarily specific for CLL. They also inhibit other cells in our immune system, and that increases the risk of infections. Of course, patients who, if they didn't receive the therapy, would also have significant risk of infections because the CLL paralyzes, to a certain extent, our immune system, especially when it's very advanced. Diarrhea or colitis is another common issue with patients who are treated with PI3 kinase inhibitors. Low-grade diarrhea for most patients is not a big deal. Sometimes you can take Imodium. But we know from the preclinical models, the models that we used prior to starting these therapies in patients, that colitis or inflammation of the colon itself is a risk factor, is a risk for patients. Now, thankfully, frank colitis is a relatively uncommon issue for patients. It happens probably in less than 5% across the different PI3 kinase inhibitors. But when you get with someone to have it, it's a very significant issue. Sometimes you have to stop the medication. Sometimes patients have to be placed on steroids. They can have very bad diarrhea, bowel movements 5, 10, 12 or more bowel movements a day. And so it can be a very challenging side effect if it's to occur in patients. Pneumonitis basically means inflammation of the lung. And so these are the colitis and the pneumonitis are what is known as autoimmune events. The PI3 kinase inhibitors can disinhibit parts of our immune system, basically takes the brakes off a part of our immune system, and it causes this inflammation that we can see in patients who've been on these therapy. Thankfully, pneumonitis is a relatively rare side effect across the different PI3 kinase inhibitors, but it can be a serious consequence if someone were to have it, and requiring often, definitely discontinuation of therapy. And generally, it can require treatment with steroids. Well, there's a more recent, I talked about that drug umbralisib to begin with. There's a recent drug called umbralisib that's been FDA approved for other diseases such as Flinn lymphoma, and it's been approved for the treatment of marginal zone lymphoma. There's a trial known as Unity, in where half the patients received the then standard therapy of the anti-CD20 monoclonal antibody obinutuzumab plus chlorambucil, and the other half received umbralisib, the PI3 kinase inhibitor, and ublituximab, which is another CD20 antibody. And again, the same Kaplan-Meier curve analysis that I showed you earlier with the other drugs. Here you can see that those patients who received the so-called U2 regimen of umbralisib and ublituximab did better than those patients who received obinutuzumab and chlorambucil. And so we hope that this drug will also be FDA approved in the near future. It's been FDA approved for the treatment of other lymphomas and related disorders. The overall response rate in this study was significantly higher in those patients who received the U2 regimen. This is an IRC assessed response rate. So an IRC stands for Independent Review Committee. So we know that, that in this case, an independent review committee, they're blinded. They do not know which therapy a patient received. They're just looking at purely at the data that they received in terms of white count, anemia, thrombocytopenia, CT scans. In this independent response committee, there was a higher overall response rate than what we saw with the control therapy. It looked like the magnitude of the difference was higher in those patients that were previously treated or had more other adverse prognostic factors, such as prior therapy with the BTK inhibitor. The magnitude of difference was substantially different. So it looked like those patients who had had these previous experience, they benefit even more than those patients who had perhaps not had prior therapy or did not have previous exposure to a BTK inhibitor. The events of clinical interest are listed here. As you can see, the adverse event profile is similar to what we saw with the other PI3 kinase inhibitors. Perhaps the number of events that someone had, such as increase in their liver function tests or colitis or infections, there maybe this was less than seen with the U2 regimen, but the specific ones that we're worried about carry over from this compared to what we saw with the other PI3 kinase inhibitors. It's just so interesting to understand what sort of the background rate is with the therapy such as obinutuzumab and chlorambucil. Here you see that even with obinutuzumab and chlorambucil, there is an incidence of opportunist infections. There is an incidence of increased aminotransferases, AST and ALT. So as hopefully you've seen, there are a common set of clinical events of clinical interest or serious side effects across these different PI3 kinase inhibitors. They include liver inflammation, pneumonitis, diarrhea, colitis, and infection. And they may vary the incidence may vary according to these different inhibitors, but we have to be wary, have to watch out for these different side effects, regardless of the PI3 kinase inhibitor that one uses. Now, as I mentioned, it's not so simple as having, as I talked about earlier, with these signaling pathways. There's not so simple as just having one pathway. There are many different pathways. And many of these do converge on the PI3 kinase, on PI3K. And so by inhibiting this, we may inhibit many of these different pathways. But it turns out, and unfortunately, that's also an oversimplification. There are many different pathways within CLL, and they don't all necessarily end up in the PI3K or pass through the PI3K. And so one of the important future directions or studies that are now ongoing is looking at ways of combining the PI3K with other drugs such as venetoclax, so that we can hit these other pathways that don't necessarily go through the PI3K, or perhaps the two agents together may be synergistic and develop greater remissions for patients. So as I mentioned, combining the PI3K with venetoclax and also with CD20 antibodies is an exciting avenue of research. I think it's exciting for a couple of reasons. Not only does it hit multiple different pathways that perhaps the PI3K do not necessarily pick up, but it also allows patients to receive therapy for a fixed duration. One of the exciting developments in the treatment paradigms for patients with CLL is to perhaps get away from the continuous drug therapy that we've seen recently with perhaps the PI3K inhibitors, but also with Bruton's tyrosine kinase inhibitors. So these therapies in general, you take them for as long as they help you, or they're not causing serious side effects. But therapies with venetoclax, we know that we can give patients a therapy for a fixed duration. Sometimes that's a year, sometimes it's 2 years, depending on which line of therapy we're using it in. And so if we combine the venetoclax and CD20 antibodies with a PI3 kinase inhibitor, the hope, the promises here is that we can give someone a therapy for a fixed duration, maybe it's a year or two. And by doing so, we may avoid some of the long-term toxicities that we're seeing with the PI3 kinase inhibitors. I think you get a patient off the drug and they're not going to get the side effect. And it may also open up other opportunities to use a different dose of the drug, or a different schedule. And in fact, it's interesting that we've been studying these therapies for years. I mean, the first studies with idelalisib were done in the late 2000s. I think it was 2009 that the first presentation for idelalisib was given. And it's amazing how little we know about what is the right dose and what is the right schedule. By dose, I mean, we know in studies in patients that we can inhibit the PI3K effectively with these oral medications. And previously we thought we had to continuously inhibit them to get the best results. Well, in studies in other diseases such as in follicular lymphoma with other PI3 kinase inhibitors, we see that by using intermittent dosing and perhaps using lower dosing, then we can get perhaps the same results, keep patients on therapy longer, but give them less of the drug, and perhaps that would be a more efficacious approach to doing this. And by doing this, and perhaps by using this intermittent dosing, we might decrease some of these autoimmune side effects I mentioned, such as the colitis, such as the pneumonitis. I know that others around the world, around the country, have had experience with, as I have, that perhaps when someone develops a side effect, we lower the dose of the PI3 kinase inhibitor. Oftentimes, patients can stay on that for years. And so there's a lot to be learned about what is the right schedule, what is the right dose, and perhaps how we should be combining this with other agents to get the maximum effect with the least number of side effects. So in summary, the PI3K inhibitors are potent oral medicines that target the same B cell receptor target that we see with Bruton's tyrosine kinase inhibitors, such as ibrutinib and acalabrutinib, but also inhibit other pathways that come from the cell surface and other signaling pathways that drive chronic lymphocytic leukemia. They are very effective in controlling CLL, even when patients have failed other therapies such as Bruton's tyrosine kinase inhibitor or venetoclax. But so far, the use has been limited for patients by their tolerance. Some of these side effects that I mentioned, such as diarrhea, colitis, pneumonitis, developed. And so hopefully with some of these newer drugs that are in development for CLL, they overcome some of these side effects, but also using some of the drugs that we've already had FDA approved or about to be FDA approved, using innovative dosing schedules to lower these side effects and combine them with other medications that allow a fixed duration therapy and allow patients to come off the treatment so that they can avoid some of the side effects that I just mentioned, while still enjoying the great responses that we've seen with these therapies. Thank you for your attention.
Thank you so much for that excellent presentation. I also want to compliment you on explaining a Kaplan-Meier curve in a way. They're thrown up in front of patients all the time, and I think explaining them and demystifying them is really important. So thank you so much for sharing that. We've received a ton of questions, some before, some after. As always, not all of them are on exactly on the topic on 3IP kinase inhibitors, but we'll be. So I'm going to ask you some basic questions first, and then we'll focus on the PI3 kinase inhibitors. One patient was wondering about diagnosis. Patient was diagnosed with indolent B-cell lymphoma, and only years later was that found to be actually CLL. Can you explain how that might happen and what the significance of that might be?
Sure. I mean, I think so. One form of indolent lymphoma is small lymphocytic lymphoma. Small lymphocytic lymphoma is basically, I would call it a tissue variant of CLL. I mean, when patients have large lymph nodes that are enlarged, we call it small lymphocytic lymphoma. When they have a high white blood cell count, we call it chronic lymphocytic leukemia. When they have both, we call it chronic lymphocytic leukemia. But under the microscope, the pathologist, the cells are exactly the same. They're the exact same cells. It just has to be where the cells go. And so sometimes they have a affinity for the lymph nodes, and sometimes they form a white count. But basically, it's the same disease, and for the most part, they're treated exactly the same.
This patient also asked about trisomy 12 or having an extra 12th chromosome. Can you explain the significance of that?
And it turns out it probably doesn't have a huge significance. It's neither good nor bad. It's what we call sort of intermediate. And so unlike some of the other chromosomal abnormalities that have much more important from a prognosis standpoint, in this case, for my patients, I would say don't worry about it. It's really not going to affect anything that we do.
There was a number of questions, and I know you went over this, but if you could just do one more time, explain a little bit about the differences and similarities in the pathways of BTK inhibitors, which I think a lot of patients are more familiar with, ibrutinib and acalabrutinib, versus the PI3 kinase inhibitors, the two approved ones, aduvelisib and idelalisib, umbralisib, which I guess can be used off-label now, and is hoping that we'll see an approval soon. Can you explain the difference between those two, the differences and similarities? Yeah.
Well, both the Bruton's tyrosine kinase inhibitors and the PI3K inhibitors are what we call B-cell receptor pathway inhibitors, but they hit different steps in that ladder or the staircase that I mentioned, and then sometimes the way you get to that pathway is also different. So I kind of think of the PI3 kinase inhibitors being a little bit downstream of of the BTK inhibitors, and that's can be good and that can be bad depending on where some resistance can occur. More proximal, you're more likely to. I mean, I'm trying to think of a better way of saying this. But basically, they hit similar. The net result is similar, but the PI3K inhibitors can be activated through other cell surface receptors driving this, and there's you really almost need like 3 or 4 dimensions to picture these pathways, right? I mean, they're it seems like this simple linear approach, but in reality, it's coming from the signals come from many different avenues to drive the malignancy forward. I don't think I did any better, frankly, Brian, just explaining that than I did earlier, but hopefully just by a slightly different approach, people understand that.
Yeah, what I tend to say is the raison d'etre, the purpose in life for a B cell is to communicate with other B cells, and it does this through the B cell receptor, BCR, and that is sitting on the top. It's like an antenna sitting on the cell surface, but it's got to get to the nucleus, the DNA, to make the proteins and do what it has to do. And if we can block that connection, we block the cells from proliferating and surviving. And we can do it different ways. One way is through BTK and blocking that, which ibrutinib, acalabrutinib, zanubrutinib, and other new drugs are doing. And the other is through blocking PI3 kinase. And they're different parts of that message from the antenna on the surface to the nucleus in the center of the cell. That's kind of the way I try to explain it. And they both work together. Help me. So I just want you to be clear on this, because there's been some questions and people are confused. A kinase inhibitor blocks an enzyme, but BTK inhibitors are different than PI3 kinase inhibitors, right? They block a different set of enzymes.
Correct. I mean, again, back to the analogy we used before, that if you look at, it's a different step in those pathways. It might be, in some sense, it's a different pathway completely, and so it's a different. So you're targeting different enzymes in this case, but the net result is that by inhibiting either one of these, and actually there's a whole bunch of other targets that can also be inhibited in these pathways, you cause the result of the death of the CLL cells.
So we've gotten this far without mentioning COVID. Let me ask you a question. There's been a ton of research on BTK inhibitors and how they might affect vaccine efficacy and outcomes with COVID, some on venetoclax, some not encouraging news on CD20 antibodies in terms of the ability to form, have a response with antibodies after the vaccine. Is there anything on the PI3 kinase inhibitors and vaccine response?
I haven't seen specific data on that, but I would expect them to have the similar bad effects on immune responses for patients with CLL or any disease for which you're taking one.
Some PI3 kinase specific questions. Tell us a little bit about mutation and unmutated. We know that the BTK inhibitors are largely agnostic to that. They seem to do well with both groups. You showed some data on duvelisib that seemed to suggest, is that generally thought that for all the PI3 kinase inhibitors, they'll work well with both the mutated and the more aggressive unmutated patients?
Yes, that's right. I think that it works across these different subgroups, unlike chemoimmunotherapy. And most of these prognostic factors that we think about today were developed in the chemoimmunotherapy day. Thankfully, the novel therapies, BTK inhibitors, venetoclax, and the PI3 kinase inhibitors, largely overcome that. I think perhaps the one group of patients that still they do better, surely better with these novel agents, but not quite as well as we would hope, are the patients who have the problems with P53, the 17p deletion. It's a substantial improvement, but over chemoimmunotherapy, but there's still a difference.
A couple questions about when the PI3 kinases could be used. They can be used in patients who just have SLL, like some patients. Well, after other therapies, their blood will be cleared. their bone marrow sometimes is even clear, but they have persistent lymph nodes. So they've got it's not really SLL, but they've got like persistent lymph nodes, or patients with SLL directly. Is this a place where you'd see PI3 kinase inhibitors being helpful?
I'm not sure I completely understand the question.
Well, where there's the main issue is lymph nodes rather than the blood or the bone marrow.
Absolutely. We know that these drugs work really well across the indolent lymphomas, right? So they also have FDA-approved indications for SLL as well as for follicular lymphomas. But like CLL, even all these diseases, you don't want to treat necessarily just because you have a lymph node. You want to wait until someone has symptoms of the disease, or you think they're about to get symptoms, that the disease is progressing, and then intervene.
So there was a question on that, and if you could just remind us, what are the indications to treatment, and why don't we treat, like in other cancers? I mean, this is a question you as a CLL expert must get all the time. I mean, we don't wait until the breast cancer is spread. We treat it the minute we catch it, So why is it different in CLL, and what are the indications for treatment?
Well, yeah, that's a really important question. So when patients come in, I first explain them that we're not going to do anything. We're going to, so-called watch and wait. Most people think that's crazy, right? I mean, everything we know about therapy for cancer is that the early intervention leads to better outcomes for patients. And this is, CLL is one of the few exceptions to this rule. The reason is that there's been studies done over decades that show that the early intervention does not make better outcomes for patients than later intervention. And so a lot of times patients come in and they have no symptoms at all. And I say, we have excellent therapies right now. I mean, I think it's amazing in the last 10 years how things have changed. But intervening now, I'm only going to give you symptoms rather than make things better. And so if we wait until you're about to develop symptoms, then we're much better off. We give you that period of time without any happening on any medication, and you don't have that. Now, the indications for treatment are the same today as they were when I began my career. They are low platelets, so thrombocytopenia, low red blood cells, so anemia, someone's anemic, someone who has very large or progressive lymph nodes that are becoming symptomatic. Occasionally, someone will have such severe fatigue that they require therapy. But in my experience, that's rare. It's generally combined. When they have that degree of fatigue, that usually something else is coming along right behind it, another reason for treat. And then finally, the lymphocyte doubling time is often used. Again, it's in and of itself, we know that the white blood cell count, the lymphocyte count, really doesn't matter. But if it's rapidly doubling, like going from 50,000 to 100,000 in 6 months, well, in general, we're probably not better off waiting any longer, and might as well treat at that time. But if it goes from 10,000 to 20,000 over a couple of years, then really that's not a reason to treat.
And I would add, though it's not seen that much in CLL, is the B symptoms, the fever and the night sweats, the unexplained weight loss. But we don't see much of that in CLL, do we, Dr. Flinn?
Yeah, no, I see it. Sometimes I worry about someone, whether there's the so-called Richter's transformation, and so it's generally not seen on the frontline therapy, but later in the course of disease, sometimes we start seeing this. And so if someone suddenly feels terrible, can't get out of bed, they get night sweats, they're wasting away, as you say, then I really worry that we need to start looking to make sure that it hasn't converted to a more aggressive lymphoma.
So let me use that as a segue. What about using PI3 kinase inhibitors frontline? Are they used frontline? And umbralisib, is that going to be a change in terms of the other PI3 kinase inhibitors in terms of a frontline therapy?
So if right now they're not used frontline, the reason they're not used frontline is that the side effect profile is such that that people start to pick up more of these autoimmune events, and there's a lot of theories why that is. Patients who are frontline may have a more so-called competent immune system. Their immune system is not hasn't taken a hit from the long therapy or the treatment of it. And so we think that people have more competent immune system, more prone they get some of these autoimmune events, such as the colitis and such as the pneumonitis and even the liver function abnormalities. So right now, it's not, we generally would not use them as frontline. Umbralisib has been and is being investigated as a frontline therapy for patients with CLL, and we'll have to see, whether it ultimately gets an indication there and whether it can be approved. I think it's probably a little bit of a testimony that it's probably a little bit better tolerated PI3 kinase inhibitor than the other ones that we've seen, because it can be used in the frontline setting. But it's really going to take a lot to displace the therapies that we already have in the frontline setting, such as venetoclax and such as the BTK inhibitors. And so my guess is that all the PI3 kinase inhibitors will largely be used in second or third line therapy for the time being, unless we develop some of these new novel combinations. So one of the other so umbralisib is being investigated with venetoclax and ublituximab in both the frontline and relapse setting. And by that sense, we may be able to, and again, it's a time-limited therapy, so people aren't on all these therapies forever. So by using that, we may be able to get people off therapy relatively quickly, and so they don't minimize some of these adverse events or side effects.
Now, I think you're alluding here to the ULTRA-V trials, and we've had a number of questions on that. So could you explain that trial, and is that trial still open?
It is still open, and it has recently changed design. It was a single-arm study where people got the umbralisib, ublituximab, and venetoclax in as a single arm. Now it's a randomized trial, and patients, and half the patients are getting that regimen, and the other half are getting the so-called U2 regimen, which is umbralisib and ublituximab, we saw in that Unity trial. And so I think it's a very interesting study. I have a number of patients that are participating in this trial. I think it's a great trial.
And is that for relapsed refractory or frontline or both?
Actually, it's for both. It's a unique design. We don't see that in a lot of trials, but yeah, it allows patients who have not had prior therapy as well as patients who have had previous treatment.
So patients have specific questions about when PI3 kinases might be a good option, and help me in how well they might work in these settings. So let's run through some of the questions. Someone's had FCR and is now relapsing. Would a PI3 kinase be part of your discussion with the patient?
Well, it certainly could be, but I think because of the things that I just mentioned in terms of adverse event, I would probably not, outside of a clinical trial, I would probably not recommend that as, I'd probably recommend one of the other novel agents before going on to a PI3 kinase.
So let's go in that other direction. Someone's failed ibrutinib or failed venetoclax. Could you consider a PI3 kinase in those settings?
Yes, definitely. I think it's a good option for patients who have who failed those other medications for sure.
And remind us that the two that are approved in umbralisib, which is the coming one, are all oral agents, correct?
That's right. So idelalisib, duvelisib, and umbralisib are all oral agents.
All right. And what about combinations? You've talked about the combination of umbralisib with an antibody. You've talked about venetoclax in combination. Are there other combinations that are out there? And are they ever combined with BTK inhibitors?
So I'm not, those are the most common studies that are being done. And at least we've looked at in the past with combining with chemoimmunotherapy, but I think we saw increased adverse events. And frankly, I think people are trying to get away from chemoimmunotherapy, so that's not all that attractive a result. BTK inhibitors, there has been there's a concern, I think, by using that combination, certainly not in clinically, but there's a concern about using that combination that we might get increased side effects. And so I think it's only in a clinical trial, and I'm not aware of one right now that's going on with it, maybe, but only in a clinical trial would I use that.
But the combinations with antibodies and with venetoclax are ongoing and been helpful. Yeah. What about age, over 70, PI3 kinase inhibitors, a young patient who might be on it for long term. Is that a factor you as a clinician saying, okay, obviously it's not a frontline therapy, but you're saying to a patient, let's look at this now. You've maybe used a BTKi, venetoclax, chemo is off the table for a lot of reasons. Would the age be an issue, somebody over 70 or somebody, let's say, in their early 40s?
No, I don't see age as an issue here at all. I think that it's an all-oral therapy or at least duvelisib is. You can, and umbralisib is potentially. It's relatively easy to use. I would not see age as an issue. If someone, the younger patient who's had numerous prior therapies, then I think this is an attractive option for that patient as well.
And again, to be clear, this is not only for high-risk disease. Generally, I would think that by the time you get to it, the disease has evolved to become higher risk, but this would work well on someone who's lower risk too. Is that correct?
That's exactly right. It works well. I mean, that one trial I showed you with, I think it was the Unity trial, where there was a greater magnitude of benefit for those patients who had higher risk. But as you point out, we're often using in these now just because of the paradigms we're using. We're often using it as sort of third line therapy. By that time, most patients have more aggressive or recalcitrant disease, meaning they're not responding as well, and so it's a great therapy for them as well.
We talked about enlarged lymph nodes, and these are very good at shrinking lymph nodes. What about an enlarged spleen? Is it effective in that? We know that the BTKs are pretty effective in that setting. Is that your experience that it might be helpful here?
Yeah, absolutely. Like what we see with BTK inhibitors, you see the same exit of lymphocytosis that occurs. So you put patients on this medicine, the lymphocytes leave the bone marrow, they leave the lymph nodes, they leave the spleen, and they go out into the peripheral blood where they can peak and then ultimately die off over time. So it works on all the different compartments, we call these, the marrow, the spleen, the lymph nodes. It works very well in all these different compartments.
Is there a limit to how long people can stay on a PI3 kinase inhibitor if they're tolerating it well?
No. I mean, I've had people on, I gave some of the first doses. I gave the first doses of idelalisib in that early phase 1 trial. I had patients on idelalisib for years. I mean, more than 5 years. As I said, oftentimes for reasons that I don't, many times it was patients who had an adverse event. We lowered the dose and they had stayed on a lower dose for a really long time. So I've had patients on almost all these different PI3 kinase inhibitors for many years. And as long as you're tolerating, you're not having side effects, there's no reason that you need to come off.
And you mentioned a term, and I'm going to ask you just to clarify that, opportunist infections. And that occurs, I think, with just about every treatment. That occurs with CLL without treatment, but it also occurs with just about every treatment. Can you remind us what an opportunist infection is and why patients should be concerned about that?
Yeah, absolutely. So there are infections that anybody can get, right? You can get pneumococcal pneumonia that, and whether you have CLL or not. But opportunistic infections are sort of what they sound like. They're opportunistic in that they occur really only in the setting of immunosuppression. And so, for instance, it's a pneumocystis pneumonia. It's an organism that only really flourishes when someone's immune system is not working properly. So that's one. There are other opportunistic, like cytomegalovirus. It's an infection that only occurs in patients that, I'm sure there are exceptions, but only occurs in patients who have their immune system is suppressed. And the most commonly we see them in, these are the same kind of infections we see in patients who are having bone marrow transplants or solid organ transplants that because in those settings they were purposely suppressing the immune system. In this case, the immune system is a sort of a side effect of the therapy that we're giving and the underlying disease.
If a patient develops a complication of a BTK inhibitor, let's say atrial fibrillation on ibrutinib, would a PI3 kinase be an option for them to consider?
It sure is. I mean, I think that, hopefully the doctor would go through and say, well, what were the next options? If the person hadn't had venetoclax, that would be a reasonable option, but there are reasons why people can't get venetoclax, such as problems with kidney function. And so I think a PI3 kinase inhibitor is an important consideration for someone who's either intolerant or failed Bruton's tyrosine kinase inhibitor.
So we have a couple minutes left. I just have to ask about a couple things. Your thoughts on related to COVID, your thoughts on the booster vaccine, what a booster shot for your patients, what you're advising them. And if you could comment on the monoclonal antibodies, there were some positive results of the Provent AZD 7442 trial. I wonder if you went on to comment on that, and the expanded emergency use authorization of RegenCov for post-exposure prophylaxis. If you want to tell me what you're advising your patients in that regard.
So a lot to talk about there. I mean, first of all, I hope everyone will be vaccinated. The timing of vaccination is a little bit controversial, and I think it's a moving target for patients. I'm telling my patients, if you're about to stop therapy and you haven't already been vaccinated, then maybe you would want to. So if the therapy is about to complete itself, then maybe you want to wait a month or two once it's and then hopefully have the best vaccine. On the other hand, if the therapy is going to be ongoing, then you should be vaccinated. And that includes the booster shot. I hope everyone also applies the same rules for booster. The other thing I tell people is that unfortunately we really don't know whether you just because you've been vaccinated doesn't mean you can forget all the precautions, right? You still have to take all the precautions, because even patients who aren't on therapy, you're not likely to mount as robust an immune response as someone who does not have CLL. And so some people will mount a response even if they're on a BTK inhibitor or other therapy, but many will not. And so I hope they'll take the precautions. And some say, well, why would if you don't think I'm going to mount a response, then why would I bother getting the vaccine? And in that case, I'd say, well, we still don't know about. There's a whole other part of the immune response called the cellular response, and we don't have a very good data on what your cellular response would be, less besides the antibody response, and every little bit helps. Now, I think you also, if I missed anything, you can ask me again. But you asked about getting the monoclonal antibodies that are therapeutic for COVID. And yes, in our practice we are sending patients with monoclonal antibodies if they have developed COVID, because I think anybody in this patient population is high risk for developing the disease. And I don't know, Brian, I don't know about yet. I'm not sure I'm knowledgeable enough yet to have recommendations about the post-exposure prophylaxis yet. So I haven't formed an opinion about that.
Yeah, we're recommending that people have a COVID plan together. We have that on the website, downloadable, that includes, if you test positive, where you can get the monoclonal antibodies. And because not all places have it, but the NIH has a map and you put in your zip code. So we're recommending that. Any final thoughts on PI3 kinase inhibitors? This was incredibly helpful, I think, and gave us a broad perspective. Any final thoughts you want to say to patients?
I think they're an important part of our treatment armamentarium, and so we need to keep this in mind when making treatment decisions. Just in general, I think that because they are associated with some side effects, that I often use the other therapies before going to a PI3 kinase inhibitor. But if someone is intolerant, has reasons that they can't take one of these therapies, or has already been treated with them, then I think that's a very important treatment option for patients.
Well, Dr. Flinn, I want to thank you again for this very clear and helpful presentation. I apologize if we didn't get to all the questions, but you can email us at support@cllsociety.org or reach out. I want to thank again our sponsors, Adaptive Biotech and Bristol Myers Squibb, for making this possible. I want to thank all of you, because being involved with your therapy. Our motto is smart patients get smart care. And I think you're going to be a lot smarter than you were an hour ago about PI3 kinase inhibitors. And I really believe the best news is to come. I'm really excited about the potential for umbralisib and new dosing schedules and better understanding of these PI3 kinases down the line. Thank you very much for your attendance. And I look forward to seeing you at future events. Thanks again, Dr. Flinn.